Ladies and gentlemen, dear friends, welcome at the webinar of the International Society of Gynecological Endocrinology. This webinar on the role of progestogens in menstrual cycle-related bleeding disorders has been is sustained by an educational grant of Abbott, who allow us also to have the beautiful 6 languages translation program. Today we will have two speakers, Professor Efthimios Deligeoroglou and Professor Rossella Nappi. I will introduce now first Professor Deligeoroglou, and after its presentation, I will introduce Professor Rossella Nappi. At the end of the two presentations, we will have the general discussion. Please write your question in question and answer. I will read the question and I will introduce the question to the different speakers. And it's my pleasure now to introduce Professor Efthimios Deligeoroglou. Efthimios is Professor Emeritus of National and Kapodistrian University of Athens Medical School in Greece, as well as head of the Division of Pediatric Adolescent Gynecology of Mitera Children's Hospital and president of the Hellenic Society of Gynecological Endocrinology. He has been chairman of the second department of obstetric gynecology in Aretaion Hospital in Medical School, National and Kapodistrian University of Athens, Greece, and also vice president of F48 Board of Directors of Aretaion Hospital in Kapodistrian University of Athens in Greece. He's also served at National and Kapodistrian University of Athens as head of the Department of Mother's Child's Health of Medical Science. He's member of a huge number of medical societies, and he has served as Vice President and Secretary General of Federation of International Society of Gynecological and Adolescent Gynecology, and also is still President and Secretary General of several Hellenic societies. He had a huge number of publications, 889, and with more than 2,800 citations, and he participated to a huge number of congress. I cannot tell you how many are, because Efthimios is a very long time far from your university, but more than 1,000, and as invited speaker with 25 international and Hellenic awards and publications. Okay, then Efthimios, you have your presentation, which will be dedicated in a very important chapter, which is the role of progestogen in the management of abnormal uterine bleeding in adolescents. Thank you very much. You can
Thank you, Professor Giannazzani, for the kind invitation and the introduction. Ladies and gentlemen, it's a pleasure to be with you. It's a pleasure to be in this webinar with Professoressa Nappi, with all of you that assisted in this trial to participate, to give more information about the treatment of abnormal uterine bleeding, about the treatment of dysfunctional uterine bleeding. And thanks once again for the kind invitation, Professor Andrea Giannazzani, my close friend. Let's go to start.
Yes, you can share your screen.
Yes. The history of abnormal uterine bleeding, menstrual cycle abnormalities have been reported since ancient times. In the aphorism of Hippocrates, it was the first attempt in history addressed to heavy menstrual bleeding. To stop excessive evacuation of the menstruation, a large cupping glass may be applied to the breast, and menstruation, if too abundant, produces disease. Few years later, Aristotle tried to define excessive bleeding in several ways in direction for midwives, counseling women for childbearing, and about the definition, the normal bleeding. For most girls, menarche usually occurs within 2 to 3 years after the appearance of breast pads. The mean age of menarche varies somewhat based on ethnicity, from 12.7 years to 12.3 years old. Many teens then experience irregular periods for 2 to 3 years following menarche because of anovulatory cycles, and an immature HPO axis. Once regular menses are established, normal menstrual cycles are from 21 to 40 days long, with bleeding usually lasting from 2 to 7 days and an average blood loss of 20 to 80 milliliters. What about the menstrual cycle and the HPO axis? A balance of positive and negative feedback mechanism generates secreted in an increased pulsatile fashion in hypothalamus and then transported to the anterior pituitary. The anterior pituitary secretes FSH and LH, providing input to the ovaries. In the ovaries, FSH stimulates the granulosa cells to convert androstenedione to estradiol. LH stimulates then cells to produce progesterone and androstenedione. Estradiol and progesterone generates FSH and LH production and release. What about the hormonal regulation of ovarian cycles? First of all, follicle factors maintained follicular sensitivity to FSH. Ovulation is triggered by the rapid rise in levels of estradiol. A positive feedback results in the mid-cycle surge of LH, explosion of the egg and the formation of the corpus luteum, a rise in the progesterone level and the second rise in the estradiol level produces the day 14 luteal phase, characterized by the low FSH and LH levels. FSH secretion is suppressed by estradiol and progesterone in the early and mid-luteal phases. FSH increases toward the end of the luteal phase, initiating a new cycle. The hormone-induced changes on the endometrium, postmenarcheal reepithelialization, endometrial proliferation, epithelial secretion, estrogens and progesterone, premenstrual ischemia, stasis of blood in spiral arteries, endometrial spiral arteries, vasoconstriction and collapse of all but the deepest layer of the endometrium. In early to mid-luteal secretory phase, induced the decidularization reaction around blood vessels, augments expressions of human endometrial stromal cells, angiopoietin 1 and the homeostatic agent that stabilizes vessels and blocks further unstable angiogenesis. In mid-luteal secretory phase, is associated with maximal hemostatic, antifibrinolytic, and pretorinolytic properties to mitigate the potential pregnancy threatening to hemorrhage during implantation. Following the eventual failure of conception, progesterone withdrawal creates a pro-hemorrhagic environment around endometrial blood vessels, promoting menstrual bleeding. The impact of menstrual bleeding disorders, menstrual disorders are major health concern. They have significant impact of the overall health and the social cost incurred across the world. Worldwide prevalence is approximately from 3% to 30% among reproductive aged women. Half of affected women do not seek medical care. The manifestations vary from modest to severe disruption of work productivity and quality of life. Women can have extremely different experiences based on their individual perception, symptoms, and livelihood. What about the percentage? Menstrual bleeding disorders worldwide, such as Turkey, 16% abnormal uterine bleeding. In Mexico, 5% amenorrhea. In Brazil, 35% heavy menstrual bleeding. In Arabia Saudi, 65% heavy menstrual bleeding. In Russia, 32% heavy menstrual bleeding. In China, 18% heavy menstrual bleeding. In India, a study of 13,626 women aged less than 50 years old, 20% abnormal uterine bleeding, and in Pakistan, 26% abnormal uterine bleeding. Presence of irregularities in the menstrual cycle involving frequency, regularity, duration, and volume of flow outside of pregnancy. An episode of heavy bleeding requiring immediate intervention to minimize or prevent further blood loss. can occur in the presence or absence of existing chronic abnormal uterine bleeding. In bleeding is abnormal in duration and volume and frequency has been present in the majority of the preceding 6 months. Older terms such oligomenorrhea, menorrhagia, and dysfunctional uterine bleeding should be discarded in favor of using simple terms to describe the nature of abnormal uterine bleeding. Excessive or prolonged blood loss originating from the uterus is defined as abnormal uterine bleeding and is a very common complaint in adolescents. Its presentation may cause significant distress to both the young girl and her parents, leading them to seek for medical assistance. Bleeding severity may vary from mild to very severe, requiring immediate hospitalization and appropriate treatment. The pathophysiology of abnormal uterine bleeding. The menstrual bleeding physiology can be affected, leading to abnormal uterine bleeding by clotting pathway disorders such as coagulopathy or iatrogenic, any derangement in the structure of the uterus such as leiomyoma, polyps, adenomyosis, malignancy or hyperplasia, disruption of HPO axis through ovulatory and or endocrine disorders or iatrogenically. The parameters about the FIGO 2018 abnormal uterine bleeding system, nomenclature and symptoms. The parameter frequency is normal, ranges between 24 to 38 days. Is abnormal, absent, not bleeding, infrequent for more than 38 days, frequent less than 24 days. The duration less than 8 days, prolonged more than 8 days. The regularity, normal or regular, less than 7 to 9 days, and irregular, more than 8 to 10 days. The flow volume is normal. Intermenstrual bleeding, bleeding between clinically, regular onset of the menses, no random, cyclic, predically, early mild to late cycle, light, unscheduled bleeding on progestogen plus all estrogen gonadal steroids. FIGO has proposed a new classification system for the diagnosis of abnormal uterine bleeding in newly gravid women of reproductive age, which has also been endorsed by the American College of Obstetricians and Gynecologists. This system, which can equally be applied for adolescent patients, categorizes the causes of abnormal uterine bleeding into major groups according to the existence of uterine pathology, and classification follows the acronym PALM-COAIN. For the following causes: polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not otherwise classified. The PALM-COAIN classification system about FIGO for abnormal uterine bleeding, you can see in the slides, abnormal uterine bleeding, menstrual bleeding, intermenstrual bleeding. The PALM system is structural causes, polyp, adenomyosis, leiomyoma, malignancy, and hyperplasia. The COAIN system, non-structural causes, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, and not yet classified. The FIGO recommendation for clinical investigation, the steps that the doctor have to do. First of all, general assessment. Secondly, determination of ovulatory status. Third, screening for systemic disorders or hemostasis. Fourth, evaluation of the endometrium. Fifth, evaluation of the structure of endometrial cavity. And sixth, myometrial assessment. The differential diagnosis for abnormal uterine bleeding in adolescents, pregnancy, hematologic, endocrine disorders, infectious, pathology of reproductive tract, medication, trauma, others such as stress, excessive exercise, eating disorders, systemic disease, intrauterine devices. The pathophysiology of anovulatory abnormal uterine bleeding, is the absence of a late surge leads to anovulation, absence of a corpus luteum, and therefore to reduce progesterone production. The pathophysiological mechanism which leads to abnormal uterine bleeding is the lack of positive estrogen feedback on the hypothalamus necessary for the mid-cycle LH surge and the subsequent ovulation. The constant unopposed by progesterone action of the estrogens on the endometrium causes the forming of a thick but loose endometrium which cannot be stabilized by progesterone. This endometrium starts shedding irregularly, resulting in blood loss. Estrogen stimulation continues, and irregular shedding endometrial occurs with abnormal build-up, thus contributing in the continuation of abnormal shedding and subsequent bleeding. What about the management? The management of abnormal uterine bleeding, the management is determined by the underlying etiology and by the severity of the bleeding. The goals of controlling abnormal uterine bleeding include preventing complications such as anemia, as well as restoring regular cyclic bleeding. Underlying systemic endocrine disorders or bleeding disorders are addressed, and patients may require referral to appropriate specialists for further evaluation and management if one of these conditions is identified. For the patients in whom no other etiology is found, management of abnormal uterine bleeding will in part be directed by the amount of flow, the degree of associated anemia, and patient and family comfort with different treatment modalities. The evaluation, step by step, and management of abnormal uterine bleeding. First of all, initial history or physical examination suggests acute or severe blood loss. Assess hemodynamic stability, unstable, emergency treatment options. The history and physical examination. The pregnancy test, complete blood count, cervical cancer screening, and additional evaluation if identified. Unstable, emergency treatment options. In this condition, the additional evaluation, if indicated, suspect coagulopathy, further investigation for coagulopathy. In cases that they have an age more than 54 years or elevated risk of endometrial carcinoma, endometrial biopsy, abnormal examination or symptoms persist after treatment, transvaginal ultrasound is indicated. Infections or hormonal cause suspected, further investigation. Abnormal, further evaluation and treatment as indicated, and treatment options for medical care of abnormal uterine bleeding. We have to give antifibrinolytic such as tranexamic acid, non-steroidal anti-inflammatory drugs, combined oral contraception, progestogens, danazol, generates analogs, and levonorgestrel releasing intrauterine device. Contraindication to estrogens. In these cases, progesterone 10 milligram once daily for 5 to 10 days may be effective for right and moderate flow. Patients also may be cycled monthly on a progesterone-only regimen, such as DMPA 150 milligram IM every 3 months, or levonorgestrel intrauterine device, which lasts for 5 years. Above methods often are associated with irregular bleeding and spotting themselves. But, ladies and gentlemen, not all progestogens are the same. Progestogens classification, progestogens distinct biological effects, receptor binding of progestogens, dihydrogesterone is a regimen that we have to do, that we have to study. Not all progestogens are the same, different molecular structures. The progesterone is structurally related to progesterone and structurally related to testosterone. It's very important to see the stereoisomer of progesterone, such as dihydrogesterone. Dihydrogesterone is 17 hydroxyprogesterone derivatives, the pregnanes, the 19 progesterone derivatives, such as norpregnate. On the other hand, the 19 nortesterone derivatives, we have to look the esteranes and gonanes. Esteranes such as linestrelone, norethindrone acetate, ethinyldrydrol disaccharides, norethindrone, dinogest, and tibolone. Last but not least, spironolactone derivatives such as drospirenone. What makes dihydrogesterone unique, Melik? Does not block ovulation and therapeutic dosage, no estrogenic effects, no androgenic effects, no glucocorticoid activity. Dihydrogesterone is highly selective for progesterone receptors, thereby decreasing the risk of adverse effect. Does not block ovulation and therapeutic dosage, no estrogenic effects, no androgenic effect, no glucocorticoid activity. Dihydrogesterone is a closed stereoisomer of progesterone, no estrogenic, androgenic, or glucocorticoid effects, does not inhibit ovulation in normal dosage, has less pronounced anti-androgenic potential in comparison to progesterone. Dihydrogesterone, shaped by light, has enhanced oral bioavailability and high selectivity for progesterone receptors. Dihydrogesterone is in the treatment of uterine bleeding. Each film cartridge tablet contains 10 milligrams of dihydrogesterone. Non-pregnancy related indication, such as dysfunctional uterine bleeding, is useful. Irregular cycles is useful. Secondary amenorrhea is useful. Endometriosis, dysmenorrhea, and premenstrual syndrome. Therapeutic indication in reproductive age regarding pregnancy-related indication. Luteal support as part of the IVF-assisted reproduction technology, infertility due to luteal insufficiency, certain miscarriage, and habitual miscarriage. Posology and method of administration for menstrual bleeding disorders, always regarding the this regimen of to arrest a bleeding episode from 20 to 30 milligrams per day per up 10 days. For continuous treatment, 10 or 20 milligrams per day during the second half of the menstrual cycle. Starting day and the number of treatment days depend on the individual cycle length. Withdrawal bleeding occurs if the endometrium has been adequately primed with endogenous or exogenous estrogen. Dysfunctional uterine bleeding is an indication for this posology. Dysfunctional uterine bleeding is an indication for treatment in these cases. In cases of irregular cycles, 10 to 20 milligrams per day, starting with the second half of the menstrual cycle until the first day of the next cycle. Starting day and the number of treatment days depend on the individual cycle length. And in cases of secondary amenorrhea, 10 on 20 milligrams dihydrogesterone per day for 14 days during the second half of the theoretical menstrual cycle. Method of administration is oral administration. For administration higher doses, the tablets should be taken evenly distributed over ever. And the contraindication, special warnings, contraindication known hypersensitivity to the active substances to any of the excipients, known or suspected progesterone-dependent neoplasm, undiagnosed vaginal bleeding, treatment for luteal support as part of HRT treatment should be discontinued upon diagnosis of abortion and miscarriage. Conditions which need supervision, such as porphyria, depression, and abnormal liver function, values caused by acute or chronic liver disease. And about the interaction with other medicinal products, the metabolism of dihydrotestosterone may be increased by concomitant use of substances known to induce cytochrome P450 enzymes such as anticonvulsants, anti-infectives, and herbal preparation containing St. John's wort. Dihydrogesterone induced in phase secretory transformation of the endometrium and recommended dosage. Dihydrogesterone is highly effective for the management of dysfunctional uterine bleeding, is well tolerated and helps to avoid major surgery. Dihydrogesterone is highly effective for the management of dysfunctional bleeding, as we see previously. Dihydrogesterone normalizes the menstrual cycle in terms of length and quality of menstrual bleed, and the improvement is sustained during the follow-up period. Dihydrogesterone regularized menstrual cycles and reduced pain and anxiety both during treatment and after 6-month follow-up. The median change in menstrual cycle duration was +7 days for polymenorrhea, less 11 days for oligomenorrhea, and less 2 days for identified irregularity. Dihydrogesterone significantly decreased heavy menstrual flow and improved health-related quality of life of women suffering from heavy menstrual bleeding. And in conclusion, we have to underline that the etiologies of acute abnormal uterine bleeding should be classified based on the Palm-Quain system. Medical management should be the initial treatment for more patients if clinically appropriate. Once the acute bleeding episode has been controlled, transitioning the patient to long-term maintenance therapy is recommended. And finally, not all progestogens, ladies and gentlemen, are the same. Dihydrogesterone is selective for progesterone receptor, reducing the likelihood of other receptor-related side effects, does not inhibit ovulation, effectively transforms the endometrium. Clinical trials have demonstrated dihydrogesterone effectiveness in the treatment of dysfunctional uterine bleeding, including abnormal uterine bleeding, a heavy menstrual bleeding, irregular menstrual cycle, a secondary amenorrhea, as we said previously. Ladies and gentlemen, we have to underline the useful use of progesterone in these cases of dysfunctional uterine bleeding, in these cases of abnormal uterine bleeding, in these cases with the luteal phase deficiency. Is very, very useful to use this regimen. Why we have to stop the bleeding, we have to stop this illness, because this illness is not only for the girl, but also for the parents of this girl. Ladies and gentlemen, I would like to thank once again for the kind invitation. I would like to thank once again all the participants in this very useful webinar. It's very useful because we have to practice, we have to do our best in these cases of abnormal uterine bleeding, of dysfunctional uterine bleeding. Ladies and gentlemen, once again, thank you.
Thank you, Efthimios, for that beautiful lecture on the management of abnormal uterine bleeding in adolescents. And now we have to go to the other side of the moon. If adolescents in one side, we will go with Rossella Nappi. She will speak about the role of progesterone in the management of abnormal uterine bleeding in perimenopause. Rossella Nappi, she is full professor of obstetrics and gynecology and chief of the Research Center for Reproductive Medicine and Gynecological Endocrinology Menopause Unit at the San Matteo Foundation, University of Pavia in Italy. And her major interests are psychoneuroendocrinology of female reproductive and post-reproductive life, with a special focus on women's sexual health. She has published around 350 scientific articles in peer-reviewed journals and international books, with around 17,500 citations, and an HF Google Scholar of 72. And she is past president of the International Society for the Study of Women's Sexual Health. And at present, she is permanent member of the advisory board of the International Society of Gynecological Endocrinology and of the Human Academy of the International Academy of Human Reproduction, and General Secretary of the International Menopause Society. Rossella, you have the microphone, and I remind to all of you to send me your question, writing in the question and answer, just that I will introduce later to our speaker. Thank you very much, Rossella.
Thank you, Andrea. Hello to everybody. I thank Professor Deligeoroglou because he made my life easier. Here, my disclosure. And the topic, my topic, it's really interesting because I'd like to start by saying that when we discuss abnormal menstrual bleeding in perimenopausal years, we have to say that this is physiological. Why is this? Because the hallmark of entering menopause is really the change of menstrual cycle characteristics. And as you can see here from this beautiful cartoon by Nanette Santoro, we may start already during the late reproductive phase with slight irregular bleeding, and then entering that translation, we have a significant change in cycle length. And especially by the end of the late menopausal transition, then we will reach the stop at the final menstrual period. But the journey is very long, and it's very, very common that we have variability in menstrual blood loss that start being associated with the onset of irregular cycles. We should say that there are a bunch of women, they are quite lucky, up to 25% of them, they have minimal changes of their menstrual cycle length before the final menstrual period. But the majority of them, and this has been very well demonstrated in longitudinal data, for example, in the SWAN study in North America, that most women experience at least 3 repeated bleeding episodes lasting 10 or more days in a period of observation of more than 10 years. And this is quite a lot because menorrhagia and metrorrhagia, they can occur in around 70% of these women. And there are also a number of them, around 1/3, they have heavy menstrual bleeding lasting 3 or more days with blood loss frequently exceeding 80 ml. So the cutoff we consider as normal. What is also important to remember to understand the role of progestogens in this particular period of women's life is that in some cases, women, they have excessive menstrual blood loss, even more than 2,500, in cycle in which they still ovulate. But these cycles are characterized by high estradiol levels. And this is a very intriguing concept I would like to elaborate a bit more. Because you see, this webinar was really encompassing the 2 periods in which women, they may experience irregular bleeding and abnormal bleeding. And you have to think about that perimenopause and even premenopause. It's really like looking at the adolescent in a mirror, meaning that anovulation is common, but it's also very common to have a phenomenon that we name loop. And this loop is leading to oligomenorrhea, polymenorrhea, heavy menstrual bleeding, and abnormal bleeding, exactly as can happen during the adolescence and puberty, and in which you have a chaotic estradiol production. Because what is happening, especially, it can happen also in every phase of a woman's life, but it's much more common to observe this luteal outer phase. All the colleagues that work in reproductive medicine, they know very well that follicles, they have different waves. And you may start with a waves that is also at mid-cycle. And this is something happening significantly, in a higher significant percentage in women of advanced reproductive age. Up to 37% of ovulatory cycle exhibit a second rise in estradiol during the mid-late luteal phase, which continued into the subsequent follicular phase. And this is the reason why we may have follicular cyst, that we may have persistent corpora lutea. And indeed, there is a strong association in antral follicle dynamics with changes in hormonal production as women age. These are beautiful studies explain very well this concept, that when we compare what is happening in women, they are in mid-reproductive age, let's say between 18 and 35, and women, they are between 45 and 55, so advanced reproductive age, we see a big difference in terms of an exaggerated elevation in late luteal early follicular phase estradiol, accompanied by lower progestogen. So at the end of the day, maybe women, they produce even a significant amount of progesterone, but estradiol is so high that progesterone is not able to counterbalance that. And this is quite physiological. And this is the reason why across the menopausal transition, we may observe progesterone still present, progesterone lower, depending on the phase of the transition. And this progesterone is not capable to counteract the tremendous fluctuation that we may observe in estradiol before the anovulatory cycle starts and we are entering the real menopause. So this period is very crucial from many different angles. The first aspect we have to consider, it's really excessive proliferation of the endometrium. This is a very elegant experiment that tried to correlate the concept that I report you before, so the loop and the luteal phase dominant cycle, with the proliferation of the endometrial thickness. And you see that endometrial growth is increased in ovulatory women who develop this luteal phase dominant follicles phenomenon. And during the transition, this results in a baseline proliferation and increased thickness of the endometrium, even during, as you can see here very clearly, the follicular phase. It's not so much, but it's something, and it will stay there. And this is very important concept. Why so important? Because if you don't have the right balance between progesterone and estradiol, we have learned that this is crucial for hyperplasia. And we really need to prevent hyperplasia, but we really need to start early in the process when we know that this phenomenon, they are start occurring. Maybe they translate in very tiny changes in menstrual regularities. But if we have a dominance of proliferation instead of differentiation, we are in deep trouble. And this simple cartoon by Angonpel summarize very well this concept. And also we have to consider there are some women, they are a higher risk. Which one they are? This is a wonderful cartoon from a very old JCM paper, but that put in only one slide what we should keep in mind anytime we face a woman that starts having some menstrual irregularity or heavy menstrual bleeding, especially if these women, they are obese, they lack exercise, and in particular in gynecological endocrinology, these women, they have PCOS or they have an ovulation. We really need to consider that we have to correct this balance, especially when women, they are reaching the age of 40 and more and beyond, because we really need to prepare well this patient to enter a smooth transition. Otherwise, we will be in big trouble. But that notwithstanding, we have also to consider that some women, they are entering menopause and they are in need of a balance for many reasons, not only because they are obese, not only because they have PCOS, but just because they do not ovulate anymore. And this is something extremely important to remember, that we have to think as a continuum, as Professor Deligeoroglou already explained to us, that we really need to consider the balance between these two concepts, proliferation and differentiation, but also we have to make sure that women, they bleed correctly. Why? Because we have realized that this perfect balance between estradiol and progesterone affect also the way the tissue breaks down, and the way women bleed in terms of heavy menstrual bleeding may depend not only from this imbalance, but also from a series of factors that are released at the time of menstruation in response to progesterone and estrogen withdrawal. And we have to consider this factor. Why? Because some of them, they are irreversible. So you can give progesterone, but if the phenomenon is already there, you cannot stop the bleed. Whereas some of these phenomenon, they are reversible. So if we add progesterone when progesterone is insufficient, we can rescue the endometrium and we can stabilize all those bunch of substances, including many factors. Think about that menstruation include vasoactive agent, chemotactic factor, monocytes, a lot of molecules. They mediate vessel permeability, vessel fragility, and tissue breakdown. And all this is for sure orchestrated by the balance, estradiol and progesterone, but it's also orchestrated by other hormones. And this is crucial in reproductive endocrinology, because we know that even androgen, for example, or glucocorticoids, they may impinge on this perfect mechanism. And when there is a derangement in terms of all these factors, we may interfere with all these subsequent steps: apoptosis, vascular maturation, inflammation, hypoxia, resolution and repair. And when all these mechanisms are impaired, we end up in having heavy menstrual bleeding. So a very recent cartoon produced by, I think, the Queen, Hilary Critchley, of the understanding of what is happening in the regulation of menstruation, put in one cartoon all the things I've told to you. And so we have to consider that when we are in physiology, following progesterone withdrawal, we have a mature specialized endometrial spiral arterioles that contract due to an increase of vasoactive factors. They are very well balanced, especially endothelin and prostaglandins. And this vasoconstriction is really imperative for limitation of menstrual blood loss. And this was very well demonstrated in measuring the diameter of the vessels, of the small vessels. And we know that when we interfere with this diameter, we may be in trouble. And when we have immature endometrial vessels and a reduction in vasoconstrictive factors, we result in larger vessels radius during menses, and we have a significant increase of menstrual blood loss, as it happened when a woman entered this premenopausal phase with some kind of pathological response of the endometrium. Endometrium that is not so capable to repair following the menses. And so we enter a pathological circle. And this is the reason why nowadays we really believe that there is an impairment of the endometrium that is related to this imbalance between estrogen and progesterone, affecting hypoxia, inflammation, hemostasis, and vasoconstriction. But keep in mind that all those pathologies that Professor Deligeoroglou already mentioned that are part of the Palmer-Cohen classification system may interfere also with the ability of the endometrium to bleed, to repair, to vasoconstrict, etc. So when you bleed in perimenopause, this may be the results of an impairment of the balance, but it may be a result also of a secondary endometrial disorder that is due by any kind of this pathology. So we have to keep in mind this when we plan a treatment strategy. We know very well the algorithm that is based on the Palmer-Cohen classification, and we have to follow different paths. Professor, my colleague, already explained to you this very, very well. For sure, in the perimenopause or in the premenopause, it is even more important to check for pathology, starting from ultrasound, hysteroscopy, all the methodology we have nowadays in order to take a biopsy. Of sure, in this particular period of a woman's life, to put a medicated IUD in the uterus can be a solution, but sometimes, as you know very well, this is not possible for many different reasons, maybe a distorted cavity, expulsion, intolerance, etc. And however, we have to consider always the two paths. The one that is physiological, anovulation, because it's typical of this age, and the path that is pathological. We have to remove the pathology, imagine a polyp or a submucosal fibroids, and then we have to set a strategy. We have many different strategies in the perimenopause, and this is a wonderful review by our president at the International Menopause Society, Steve Goldstein, and the past president, Marianne Lunsen, in which, of course, you can have an expectant behavior, you can use antifibrinolytic agent and non-steroidal anti-inflammatory drugs. We usually use this drug acutely together with progesterone to try to stop the bleeding. We can also use combined oral contraceptive to balance this imbalance between estrogen and progesterone, usually with natural estradiol or POP, progestogen only pill. We may use levonorgestrel IUS, but we may administer cyclically or long-acting progestogen. And this is the focus I want to do now to end my talk. I'd like to keep in mind to everybody that when you add progestogen, it's just because you don't want to induce the menstruation. It's just that you want to protect the endometrium. This is a very important concept to maybe to regulate the menstrual cycle and give the woman that balance in her body, of course, preventing endometrial hyperplasia and treatment of abnormal uterus. So as you see, progestins are highly polyedric, and we can combine the progestogen. We can use alone, or they can combine with hormones to help women to enter a smooth transition, either in contraception or in hormonal replacement therapy. You have seen already this very famous cartoon that not all progestogen are the same, so I will not spend so much time. I just want to remember you that some progestogen, for their characteristics, they are more suitable for contraception, and other they are more suitable to be used alone or in combination with the estrogen to offer an hormonal replacement therapy to induce a smoother transition. And dihydrogesterone is one of them. Remember that this story that Professor Deligeoroglou already told you, so that we need specific progestogen, they are highly selective on the receptor, is particularly important in women in perimenopausal years and beyond. Why? Because we need the progestin, they have a less metabolic impact and more and they are safer. They can be easily managed and they do not induce other side effects. So we always have to keep in mind that their biological activity may be different, and also that receptor may be different. And when we compare all the different progestogen, and I put the star on those progestogen that have been used in the treatment of perimenopausal women or in the premenopause alone, for example, in France, the gynecologists, they have chlormadinone acetate. We don't have in Italy alone to balance. But when we consider all this, you see that dihydrogesterone is the one that is more similar to natural progesterone. And this is the reason why we focus our attention on this progestogen. You have seen already that it's really a close stereoisomer of progesterone that has less impact because you don't have an interference with glucocorticoids, with androgen, and even you don't have an estrogenic effect. And so this may be relevant when you have hyperestrogenism in some of these women. And therefore, this translates in more selectivity, in a way that you can manage the drug easily, and also, as I told you already, less adverse side effects. You have seen already this cartoon, but this is just to reinforce you the concept that with 10 milligrams of dihydrogesterone and even 20 milligrams, as we already mentioned, you can protect very well the endometrium in postmenopausal women when you use this in a treatment that is sequential, and therefore you transform very well the endometrium and you ensure a predictable bleeding. Also, when you use in women over 35, you may control very well all those menstrual irregularities we have seen that can precede the last menstrual bleeding, so menorrhagia, polymenorrhea, menometrorrhagia, and so on. And if you use for 3-5 cycle at the right amount, usually in general we use 10 milligrams. Of course, we can adapt the dose, for example, in obese women, and for the sufficient number of days, 12, 14 days, usually according to the guideline, you may really increase the ability to conduct your patient across the transition, avoiding surgery. You may also consider this group of women, they are around 40, in which you have a comparison with the vaginal micronized progesterone, and you see that the effect of dihydrogesterone is more or less the same, is superimposable even at a little bit less days of use, 10 days, and this can be useful in clinical practice, and this was published in a randomized controlled study. And you obtain as well a normal endometrium, so you can really prove with biopsy that the endometrium is healthy. And this is a concept that is very, very important, and I would like to end with this for perimenopausal women and postmenopausal women, because you know that there is a general agreement that when we have a woman with a uterus, estrogen should be always combined, of course, with progestogen, at least 10 days, 12, 14, in order to have a safe situation in terms of avoiding endometrial cancer. And we know that when we administer a sequential treatment, we may risk a little bit more of endometrial cancer, whereas when we use a progestogen in a continuous combined regimen, we may achieve an endometrial atrophy. And it's important you consider that with dihydrogesterone, we have this possibility because we have different products that allow us to make an individualized treatment. Early in the menopause, you can administer 1 milligram ethinyl estradiol or 2 milligram, depending on the woman you have in front of you. Think about premature ovarian failure. They need more estrogen to counteract the consequence of early ovarian insufficiency. But you may, and then you may use 10 milligram in sequential, or you may use 5 milligrams. So you have a product that can allow you to treat different typologies of women. And why this is important? Because when we consider a comparison between dihydrogesterone, that is so similar to progesterone, and progesterone, micronized progesterone itself, we see that with dihydrogesterone, we have a little more protection in terms of the endometrium. And this is important because we know that natural progesterone and dihydrogesterone, they are the product that we would like to use in peri and postmenopausal women. Why? Because they are safer from a metabolic and vascular point of view. And so having this a unique progestogen will help us for sure in doing the practical management of the treatment of peri and postmenopausal women, because we know that we really need to individualize this kind of treatment. We really need to explain very well to women that the risk for endometrial cancer is small. Depends also on their compliance, on the use of progestogen. It's very important to keep in mind that sometimes women and even some gynecologists, they use less progestogen because you have some side effects in terms of PMS, migraine, headache, etc. And therefore, we really need to try to find the best treatment we can propose to the patient. And the best treatment is micronized progestogen or dihydrogesterone. And we have to select the safest product. And so this is the reason why I believe that dihydrogesterone can be used from premenopause to perimenopause and even into postmenopause in order to achieve a good control of the endometrium and improve quality of life of women when it's combined with estrogen. And with this, I thank you very much for your attention.
Thank you, Rossella, for the beautiful presentation on the treatment of abnormal uterine bleeding in perimenopause. We have now a huge series of the questions, and then I would like to invite Efthimios to open his microphone also. Efthimios, can you open the microphone? Yes,
yes, Professor.
Okay, and then we will start. Or we have a huge list of questions, and then I hope that you can provide the answer. The first question is for Efthimios, which is the most common cause of abnormal uterine bleeding during adolescence?
The lack of progesterone. The monophasic cycle is the most common cause. The monophasic cycle, the lack of progesterone.
Thank you. And then there's the treatment by following, it will be the supplementation with progesterone. Thank you. And
yes.
Then now one question for Rossella. This is from Asma Basha. Thanks for this wonderful webinar. How we can manage spotting in the second half of the cycle for women on femostone 210? Then women in menopause with femostone 210.
I don't know why you see so much spotting with femostone 210, actually. I mean, it depends on the patient you have in front of you. I believe that you already check for the endometrium. Keep in mind that what I've shown you may be just a bit faster, that when you have, for example, a uterus that had some kind of little fibroid or adenomyosis in the past, think about that. You may have less control of the endometrium because the pathology itself that is living into the woman body, maybe she was in the past, she entered the menopause, and you have difficulties in controlling the endometrium. Why? Because you have an underlying pathology. If you have the spotting, spotting, as you know very well, can be related also to an atrophic endometrium. So that maybe for that particular woman, 2 milligrams is not enough to induce a good proliferation, that then you go and you put the 10 milligram dihydrogesterone to counteract and to induce secretion. So, for example, if this woman, she's a little bit overweight, I will suggest to try to double the dose. So you can use also 10 milligram of dihydrogesterone, adding or half tablet to the 10 you're using, and you try to see what's going on. This can be a possibility. Another possibility, if you believe that the endometrium is too thin so that you have a lack of proliferation, you can even increase a bit in a woman that she's extremely thin and maybe she has an insufficient exposition to estradiol to increase a little bit the estrogen, okay? And you try to find the right balance. You can even increase the number of days you administer progestogen, and maybe instead of only the last 14 days, you can even overexpose for 3, 4, 5 days. These are tricks. I mean, it's not something that is published, okay? It's just my personal experience, and you try to balance that. Maybe you can also reduce the amount of estradiol and you can use 1 milligram. Depends really on your patient. I always look at body weight and ultrasound characteristics of the uterus.
Then the individualization is fundamental. And then one question now for Efthimios. I will translate. Is from Fernando Pineda, which is from Mexico. He asked for how long we have to give dihydrogesterone in adolescents for a cycle regularization.
For 3 months. For 3 months. For 3 months.
For 3 months. And after?
Yes, it's suggested for 3 months.
And then you stop and you follow what will happen. But can you...
We stop and see, stop and see, stop and see.
And you suggest that we can also repeat for further cycle of 3 months?
Yes, also repeat for other 3 months, yes.
Thank you very much. And then for Rossella, is there an age at which is better to start looking for estrogen-progesterone imbalance?
I look this at any age because, as you know, my love is reproductive endocrinology, and I believe that the health of women, they depend from this balance. I really believe that, and so I always check. But for sure, think about a chronological age. I look at this in women over 40 always. Keep in mind, however, that is sometimes is not only a question of plasma level, but it's really a question of the ability of the endometrium to react correctly, physiologically, to the activity of progesterone. And unfortunately, as you know very well, there are some women, they are progesterone resistant, and therefore you can give progesterone and maybe you do not reverse the process you have in development, okay? But for sure, in women over 35 or 40, to try to check if you have this phenomenon of loop, so meaning that you have a persistence of the corpus luteum, you have a deficiency of progesterone, you have hyperestrogenism relative or complete hyperestrogenism with anovulation, is important, and you have to start to correct that. And you can start with very low dose, even with natural micronized progesterone or with dihydrogesterone. They are the two more physiological, in order to keep the right balance in terms of 28 days of the cycle. Because even shorter cycle, 3-4 days that we believe is normal, they can give women anemia, fatigue, headache, etc.
Yes, and then now one question for Efthimios, which I combined from two questions rising, is that one, which situation must be immediately excluded when evaluating an adolescent with adverse uterine bleeding?
Can you repeat the answer, Professor?
Yes. Which situation must be immediately excluded when evaluating an adolescent with adverse uterine bleeding?
Pregnancy.
The pregnancy?
The pregnancy. Yes, 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 yes.
No. This
Yes.
is something which has always...
First of all, we have to exclude the pregnancy. First of all.
Yes.
First of all, in all cases.
And then one question from Edson Ferreira Filho for both of you. He asked if, he would like to know if etonorgestrel subdermal implant is an option to treat adverse uterine bleeding in adolescents and perimenopause.
May I, Rossella?
You can start
Sure.
with adolescents.
It is an option, but it's not the first choice. It's not the first choice. Yes.
And for me, it's the
In
same.
adolescence.
Of course, if you want to achieve a contraception, it can be an option if you don't use an IUD medicated with levonorgestrel, because my first choice to achieve contraception and to balance the endometrium in a premenopausal woman would be to use an IUD. But as you know, in some cases you cannot, and therefore I prefer to use a combined oral contraceptive pill with natural estradiol plus a progestin, or if the woman does not need, or there is no more, it's very rare that this woman will ovulate, I will go on with progestogen in the second half of the cycle for at least 12, 14 days. Of course, we can try, but it's not the first choice at etonorgestrel.
Agree, completely.
You agree. And then also another one for Efthimios. Which is the most common treatment used for the management of adverse uterine bleeding during adolescence? The most commonly used?
The most commonly used, you use progesterone and you use oral contraceptives. Oral contraceptives, yes. And then, oral contraceptives for 3 or 6 months, oral contraceptives. First of all, we use progesterone because the cause of dysfunctional uterine bleeding is the anovulation, the lack of progesterone. In this case, the first choice is the use of progesterone, and the second choice is the use of oral contraceptives.
And also, now we have from an anonymous a question for Rossella. If I understand correctly from Professor Nappi report, dihydrogesterone and micronized progesterone have the same risk and benefit, except for the risk of endometrial cancer, which is greater for micronized progesterone. I think that you have to better clarify this point.
Yeah, I mean, it's looking at the data and looking at the doses that usually we consider for micronized progesterone, especially in the sequential treatment, because usually we use 200 milligram, okay? It seems like that there is a little bit more of proliferation and risk of endometrial hyperplasia and cancer with natural progesterone. But keep in mind that you can increase also the dose of natural micronized progesterone. So if you believe you want to use that dose in sequential treatment, intravaginally, for example, you can use double dose exactly as we do, for example, when you support the luteal phase in younger women or in women with luteal insufficiency or in IVF treatment. So the potency of the drug seem a bit higher at the standard dose we use, 10 milligram dihydrogesterone, in comparison at the standard dose of 200 micronized progesterone. And it's true that these two progestogen, they are the most safe for the breast, the most safe for the cardiovascular system. And this is the reason why we always say that natural compounds, they are better. When you use natural progesterone, continuous combined, you achieve atrophic endometrium, exactly like when you use 5 milligram of dihydrogesterone. So this is only for that difficult time, that is the time of the transition. I've seen there is another question, Andrea, that is really related to this point. There is a colleague, Peter, I believe, that asked me something. He said, you use sequential treatment in the first year around the menopause, but there are really evidence about that. I have to tell you, my dear friend, that they are not really have some strong evidence. We just do because we want to avoid erratic bleeding. Because the problem in using combined treatment is really that in some women, if the gonad is still producing some output of estradiol, you will have menorrhagia, you may have spotting, and women, they will decrease the compliance, okay, to the treatment. And this is the reason why we use a sequential treatment, and we do that just for that 1 year. My suggestion is either you use micronized progesterone or you use dihydrogesterone, use for 1-2 years around the perimenopause, the sequential, and then switch as fast as you can to continuous combined, because I really believe that we do not need this bleeding unless women, they are really, really attached to these aspects of menstruation, such as, for example, in women, they are younger, okay, and they have premature ovarian insufficiency or failure.
Thank you, Rossella. And then now Simon Lest en Rust is asking Efthimios, I wonder if when a young girl with, for example, 2 years after her menarche start taking the oral anticonception pill for heavy bleedings, does that interfere with ripening of the hypothalamus pituitary ovarian axis? Or is progesterone only better to give her? I think that we have to consider also the contraceptive needs. Please, Efthimios, I would like your comment on this point, because it's fundamental to avoid unwanted pregnancy in adolescents.
Yes, in this case, Juan, we have to speak about the adolescents prefer to give the oral contraceptive, because we have always keep in mind the sexual intercourses in the age of 15, 16 here in Greece. That means we prefer to protect this girl with the oral contraceptives in this age 2 years after the menarche. Yes.
Yes, I think also.
And in case we have to do two different cases, we have to protect the girl for the pregnancy, the unwanted pregnancy, and we have to regularize the menstruation with the use of oral contraceptives.
We have a question, Rossella, asking if we can associate the dihydrogesterone also to transdermal estrogen.
Sure, I do a lot of this, especially when I want to use a very low dose of estradiol. So I use a gel or a little patch to help the woman to counteract the erratic production of estradiol, and then I add oral progestogen, such as dihydrogesterone. This is one of my favorite ways.
And then the question from Irina Podaneva is, for how long in such cases you administer a progestogen, and when you start in function of the menstrual cycle, if you start always after 2 weeks or longer or shorter?
It depends. I mean, as you know very well, my dear friend, there are some women, they start ovulating around the 7th, 8th, 9th day of the cycle, when they have polymenorrhea. And sometimes when they do like that, not always progesterone is enough. So I start depending on the diary of the bleeding. I forgot to tell you that it's extremely important, in my opinion, in a woman over 40 is not taking any kind of contraception, of course, to give them a menstrual diary, okay, and just to collect all the different days. And this is important because according to what you see, that you have a shorter way of entering the premenopausal years, or oligomenorrhea longer, you may play with that and you may counterbalance your patient. And so you may start a progesterone, let's say day 10 for 12 or 14 days, or maybe you start regularly at 14, 15, or 17 because you want to try to stabilize. It's always a question of a right balance. Now we have the possibility to do office ultrasound, also to check the endometrium, you know, without doing so many blood testing. It's just based on the menstrual history of your patient. This can be enough, or even ultrasound.
Thank you. And then for Efthimios, it's a question about the use or the importance in adolescent adverse uterine bleeding of antifibrinolytics.
Yes, in cases of coagulation disorders.
And then
Yes.
what is the most common treatment used for the management of adverse uterine bleeding in adolescents?
As previously I answered, the first choice is the use of progesterone, and the second choice, when we have to have a girl with sexual intercourses, we use oral contraceptives. First choice progesterone, and second choice, in these cases of girls with sexual intercourses, we use oral contraceptives.
Yes. Okay. And then for Rossella, 1 second, because we have received a huge series of questions altogether. Okay. A question is, in patients who develop a secondary amenorrhea, what should be the doses of recommended progesterone, and if alone or in addition to estrogens?
It depends on the estrogen level, but also in particular on the endometrial thickness. If your endometrial is thicker than 4 millimeter, I usually use progestogen alone. And to induce the bleeding, you can use either 10 or 20 milligram, depending on the patient you have in front of you in terms of body weight. But if the woman, she doesn't have enough estrogenization in her body, maybe you will not relieve a secondary amenorrhea by giving a progestogen. And so you have to check why the woman developed secondary amenorrhea, if this is related to premenopause, and so she has a low estradiol level, medium high FSH, you stabilize with a treatment that combine estrogen and progestogen. This is my choice.
Okay, then we are now approaching to the end. I have one question related from Gaini Zambulovna. After 2 operations of conservative multiple myomectomy, what should be prescribed for patients of 36 years to prevent a repeat of growing myoma and planned pregnancy? I think, you know.
I think it's quite difficult, my dear friend. We have a uterine transplantation. No, it's a joke. But I believe that if you don't have a distorted cavity, I always believe that the best treatment ever is to put the progestogen into the uterine cavity. But as you know very well, we don't have at the present moment SPRM anymore, just for some special category of patient. And I miss this drug very, very much, because I believe that progesterone receptor modulators, they were the real answer to your question. We can, if you are planning the pregnancy with ovo donation, another possibility can be, of course, to induce chemical menopause for 3-6 months with GnRH analog, because sometimes we have to think about that and remember that this can be done, maybe will be done in the future also by using GnRH antagonist combined with very low dose of estrogen progestogen combination. So really it's quite difficult to save a uterus that was operated several times. It's not so easy to handle that.
Yes, and then one question for Efthimios. Question is related to the acute treatment of menorrhagic menarche.
Yes. In these cases,
So
we
this can
prefer
represent-
to
Please.
we
Sorry.
prefer to give the oral contraceptives. In these cases, 2 or 3 in the beginning, and after 4 days, we go to 2 oral contraceptives per day, and then 1 contraceptive continuously for 2 months.
Okay, and then you believe, okay, and then another one. This is from Ingrid Pinas. Hi, Rossella, Andrea, and Efthimios. Good to see you all in such good spirit, and thanks for your excellent overview of progestogens in perimenopause. Despite the fact that women may not need contraception, the levonorgestrel intrauterine device is effective for control adverse uterine bleeding, perhaps also because of benefits regarding risk of ovarian and breast cancer. Do you agree? In our country, I think United States, many women undergo endometrial ablation, and sadly, this complicates the use of levonorgestrel intrauterine device. What would you recommend to those who need menopause hormone therapies after endometrial ablation?
Yeah, you know, we don't have so much experience about that because
Yes.
we don't do so many. I have to tell you that I usually use, in any case, even though if you have endometrial ablation, I use a combined treatment every day, the same. Maybe you can use a little bit less of progestogen, so maybe you can not doing every day the same dose, but maybe you can do periodically, and you do it for 1 month, and you see if there is some kind of little bleeding, because in my country it's quite common that then women, they start bleeding again if you give only estrogen. And so this is the reason, because some of them, they regenerate. I don't know if it's the technique we use in here, or if it's because women, they are obese, if they have other risk factors. So in my opinion, it's always better to combine low dose progestogen to estrogen. I don't like to use unopposed estrogen, because if you then have even only one case of endometrial cancer, this will make your life very difficult. I mean, and so I love to use IUD to do the transition. I have to tell you that it's an off-label indication, but it's really fantastic, and especially in obese patients, in women that you are not able to convince to quit smoking, etc. This is interesting, and also in women with migraine, because you minimize the exposure to the progestogen systemically. So the IUD, it's really a very good choice.
Thank you. Then now on a final question, and then I would like to have your comment in general. This is a question that I would like, Efthimios, that you answer, because this question also indicates that that person, I will not read the name, have not well understand what is the cause. He or she asks, it is appropriate to use dihydrogesterone 10 milligram for 14 days in secondary amenorrhea due to heavy weight loss in 14 years old girl. Please explain what it is, a secondary amenorrhea with heavy weight loss in 14-year-old, and what kind of treatment have to be done. You are a master on that. Please.
In this case, we have to use estrogens for have the endometrium, and after that, for have the bleeding, we have to add progesterone. First of all, the estrogens in these cases.
Thank you very much. And then, okay, now we are at the end. We have still with us nearly 500 persons, nearly 500. I would like that we make a conclusion. We will start first Rossella and then Efthimios, ladies first. Rossella, I would like that you give a final comment on your topic and a message for our participants. And then after her, please, Efthimios, you related to the addressions.
My main message is really to keep the balance of your patient, because the menstrual cycle, it's really a well-balanced phenomenon. And when women, they lose the balance, they lose their quality of life and well-being, and they may increase as well their risk, especially the risk of endometrial hyperplasia and several pathologies. So keep attention to the cycle, keep a menstrual diary for your patient, and help women to not be afraid of hormones, keeping in mind that the research, the pharmaceutical research, and even our research is devoted to understand the good of the hormones and not the bad. And we have products, they are safe, selective, and that can be used, but we have to use appropriately. And so it's important to follow the guideline in order to avoid and minimize risks. So with this, I thank you very, very much, and I wish you the best for the summer.
Thank you. Efthimios, your comment.
Yes, thank you, thank you. My comment is for the parents. The parents is obligated to give special interest in cases of dysfunctional uterine bleeding in this age of 13, 14 years old, because is a first sign of PCO disease later, as we published 2 or 3 4. That means for the parents, don't tell never, will stop. If this bleeding does not stop, go to the specialist for these cases. Yes, for the parents. For the parents. It's a message for the parents, for all the parents. For all the parents.
We are also parents or grandparents. Then, dear friends, I would like first of all to thank Professor Efthimios Deligeoroglou to have treated our difficult topic of adverse uterine bleeding in adolescents, and Rossella Nappi to have faced how to treat adverse uterine bleeding in menopausal transition, and then 2 very important chapters of our webinar. And I would like to thank Abbott for have provided us of an unrestricted grant, which was used to have so fantastic organization with simultaneous translation to 6 languages in addition to English. And then we had a huge number of participants who are still together. Then now I would like to invite all of you to follow our menstrual cycle disorder school and the course, which was started 19th of January and will end the 7th of July. All courses lessons are recorded, and then you can follow all of them in the web. And then with that in mind, I thank all of you of being with us. I thank Abbott. I thank mainly Rossella and Efthimios. Have a good summer. Enjoy the life out of COVID. And please also with peace around us. We need the peace. We have so many problems, not only in health, so many problems in education, so many problems in daily individual life, that really we don't need another war. Thank you very much. Enjoy your life. Thank you, Efthimios. Thank you, Rossella, and goodbye.
Bye-bye. Many thanks.
Bye-bye.
Many thanks.
Bye-bye.
Many thanks so much. Bye-bye.